most people think of when they think palliative care is hospice.
Right, exactly, and we're going to get into the difference between that. Because that really has a negative connotation. Does anybody, I'll throw some words out there. Does anybody, when they think of palliative care, think, oh my goodness, there's nothing more my doctors can do, they're giving up? Right? I mean, that is usually the response I get. This is, again, a very pleasant response. So most people, when they hear the words palliative care, you know, the doctor's saying, I don't have anything else to treat you. I'm a medical oncologist, I give chemotherapy, I can't give you any more chemotherapy, now we're going to palliative care. So that person's running away. The surgeon says, nope, no surgery's available, that's it. I think and if the medical oncologist can't do anything, we're going to palliative care. And so very often palliative care is equated with giving up. But what palliative care is exactly what you folks already described. It's the management. It is simply the management of the symptoms and side effects of cancer and the treatment of cancer. And who can get palliative care? Well, it's anybody that is dealing with the symptoms or side effects of cancer or cancer treatment. And it can actually, and it doesn't require any particular stage of cancer. It actually doesn't have to deal with cancer necessarily. It's anybody that's having symptoms or side effects from any treatment of any disease, but we're obviously speaking specifically about cancer. And so it is not restricted to any stage of cancer. So a person can receive palliative care who has a very early stage cancer, but is dealing with symptoms or side effects of the treatment or the cancer itself. And the other thing I think that is not well known is that you don't have to stop treatment for your cancer to receive palliative care. So palliative care can be initiated while you're still receiving chemotherapy. So while palliative care is not specifically to try to treatment to extend somebody's life or add survival to their life, it is designed to add quality to a person's life while they're receiving treatment, or if they decide not to receive treatment anymore, to continue to optimize the quality of a person's life. And I'm going to actually show you a landmark study that came out in the New England Journal of Medicine, New York Times, that's where we're starting to get all our medicine. The New England Journal of Medicine, looking at the role of early and palliative care in advanced stage lung cancer. And remarkably, what happened was the people who got early palliative care, while still getting both arms of the study, it was one of those randomized trials where everybody gets the same thing except for one part. Both arms of the study, the people got the optimal treatment for their cancer, but one group got palliative care at the same time. And they actually lived longer while getting less care. So you're right, it can actually potentially extend people's lives, despite the fact that that's not the actual focus of it. And so a lot of the thing is people feel like, you know, their medical oncologist is taking care of the symptoms that they're having. They're having some nausea, they're having some pain. Why should I get palliative care involved? And the reason to consider getting palliative care, so there's actually a subspecialty of palliative care now within the medical community. These are doctors who are board certified in complex symptom management as well as managing all the other aspects of going through a difficult time dealing with a life-threatening illness such as cancer. And so palliative care actually addresses not only the physical and medical needs, but also the emotional, spiritual, and practical needs of the patient and the family. So what are some of the symptoms, typical symptoms that we can see of advanced pseudomyxoma and appendiceal cancer? We've talked about how the disease presents. Dr. Esquivel has shown some impressive CT scans of all this massive tumor and mucin that can accumulate. And the things that we see all the time are increased abdominal girth, bloating, bowel obstructions that can occur, weight loss. People get anorexia. They just don't feel like eating when they have a large burden of tumor, or perhaps if the tumor is located around the stomach. People can have pain, whether it's from the cancer itself or the chemotherapy treatments or surgery, residual pain after surgery. You get tired. There's a sense of loss of independence. You're coming into the hospital every other week to get chemotherapy. You feel lousy for 48 hours after the chemotherapy finishes. You're barely starting to feel better, and you're back in the hospital again, and then there's a CAT scan, and there's, oh my gosh, what's the CAT scan going to show? What are my tumor markers doing? And there's just this loss of, the cancer just takes over and becomes who you are. Depression is common, anxiety about what's coming next, about what's going on in life, what impact is this having on my family. We all suffer spiritual distress, regardless of religious beliefs. This is not necessarily a relationship with God, spiritual distress really just reflects our sense of meaning in our life. And there's nobody who is going through something like this that doesn't contemplate the meaning of their life and has some component of spiritual distress. There's that sense of loneliness. People don't know what to say when they find out that you've got cancer, what you're going through, the cancer's back. There can be a sense of, and a loss of oneself just in dealing with all this. Side effects of the chemotherapy or the treatment include nausea, fatigue, again, the anorexia, weight loss. Weight loss can be so disturbing for people. That's one of the things that has really come out after the HIPEC treatment is people are shocked at how much weight they lose at recovering from the surgery. Recovering from surgery like that requires so many calories. It's like you're running a marathon every day. And you don't want to eat. And you can't eat because you feel full quickly. And so your full-time job is just to eat, right? That's all we tell you. We want you to eat and sleep and walk a little bit. That's it. And that takes so much energy. So that weight loss, which always comes back after the surgery. It always comes back. But it is shocking at how much it can be sometimes. You can get things like neuropathy, that's toxicity of the nerves. For people who've had oxaliplatin, where your fingers can become numb and cold drinks really bother you. You may have tubes draining certain things. Again, that sense of loss of control because your life is dictated by your hospital schedule. People lose jobs dealing with this. And there's obviously family stress that's involved. So these are all the things that palliative care can help address. And palliative care can take many forms. Some people don't think of surgery as a palliative care option, but if somebody comes in with bowel obstruction from their cancer, we can fix that, but we're not curing the cancer. That's palliative surgery, and that's beneficial, and that may actually prolong somebody's life. If somebody's having pain from a tumor mass, and surgery can remove that and improve their pain, that also is palliative. We can give chemotherapy. Chemotherapy can be palliative. It can treat ascites, it can shrink tumors. It may not cure somebody, it may not prolong their survival, but it can be palliative. Radiation as well. Other things that we use, medications to control pain, IV fluids to help with dehydration, nausea medications. There are alternative and complementary approaches to palliative care that are wonderful. People are coming up with all kinds of new things all the time. It involves the emotional side, the spiritual side, and then just the support group, like the support groups that people find online for the PMP, the Research Foundation. And these are so important to know that you're not alone. And who is involved? A truly multidisciplinary comprehensive palliative care program includes all kinds of providers: doctors, nurse practitioners, psychologists, pharmacists, social workers, case managers, chaplains, nutritionists. These people all meet on a regular basis to review patients and people's cases and discuss and bring their expertise together to try to help improve the quality of life for everybody that's dealing with this problem. So there may come a time, though, at which this, Dr. Sugar.
Laura, before you leave that very important aspect, could you comment, and I know a number of families here are in this, could you comment about total parenteral nutrition for this disease? I mean, we know this is a disease that basically throughout its natural history is confined to the abdomen and pelvis, and the loss of gastrointestinal function does occur while the brain is still perfect and the heart and lungs and kidneys and everything else is still functioning. Yeah. Could you say something about parenteral nutrition and when's it indicated and what sort of lines you recommend? And
absolutely, and that is an excellent point, because this is one particular cancer, for the reasons that Dr. Sugarbaker just alluded to, where I think that I personally use TPN, or total parenteral nutrition. So what he's describing is a situation where there is so much tumor in the abdomen, or it is located in places such that it really can't be removed, but it is causing a blockage of the intestines such that a person can no longer eat to maintain their nutrition. And just like he said, because this particular disease tends not to spread outside the belly cavity, it's not as if somebody is going to succumb to cancer that has spread to the lungs and they can't breathe anymore, or cancer that has spread into the liver and their liver doesn't function anymore and they're going to die of liver failure. Unfortunately, when that occurs, when the bowels become blocked and they can no longer be opened surgically and a person can't eat, they're going to starve to death. So one way to provide nutrition to somebody who can't eat and maintain their own nutrition is to give them full nutrition, all the calories, carbohydrates, fats, protein, vitamins, minerals, and everything that they need intravenously. And that is called total parenteral nutrition. And the requirements for that are you have to be able that you need a special IV catheter that goes into the big veins in the chest. And many people are already familiar with having a port for chemotherapy. It's the same type of access that you need, and you can use a port for intravenous nutrition. And usually what we can arrange for is if somebody requires that, to have it at night for about a 10 to 12 hour period. It depends on the person's size and how many calories they need to maintain their nutrition. And it can run at night at home, and it's provided there are companies that actually mix the formula for the person. It's individualized for each person, and it comes to the house and they have it. And we have kept people alive for years on total parenteral nutrition. Unable to eat, but maintaining their nutrition, and during the day not being connected to an IV, but being out and about, and people can even travel. So we can make arrangements such that people can have their TPN transported to where they're going to be staying, and they can go on vacation and live a relatively normal life. Obviously, the loss of the pleasure of being able to eat and the comfort of being able to drink is something. And oftentimes we can place a tube into the stomach called the gastrostomy tube that will drain the stomach, so that if somebody can eat and drink a little bit but not have a problem with the bowel blockage causing them to have nausea and vomiting, but they can empty their stomach through a drain tube. Those are other sort of palliative options that a comprehensive palliative care team that has surgeons involved in it can offer to people as if the disease should advance to that stage.
Do you think it makes the PMP grow more rapidly?
I've seen it both, I think. And that's one of the, Dr. Schierbeger raised another important point. So a lot of times the medical oncologists will really not recommend. They will actually advocate against using intravenous nutrition because of the concern that it can actually cause the cancer to grow. You know, it's great. It's very nutritious. It's right into the vein, and it can cause cancers to grow. And I've certainly seen that. But more with like colon cancers and other types of more rapidly growing cancers to begin with, and less so with the true pseudomyxomas. Yeah. Yeah.
I'm a medical oncologist, and that is not what we look at. We absolutely do use nutrition as a part of therapy, and we look at the best way for giving the nutrition to any individual patient. For some patients, TPN is absolutely the best way to give the nutrition, since in these patients, a significant portion of the GI tract will have been surgically removed. One of the things that we look at in terms of rapidly growing tumors, or tumors that don't grow rapidly, is the molecular aspects of the tumor. And with the number of drugs that are available now, we're finding that the molecular aspects of the tumor probably predict more regarding its biological behavior. Since in many cases we have all looked at patients, some with rapidly aggressive tumors that grow very rapidly and spread rapidly, and others that do not. And what we find is that the molecular aspects of the tumor are probably more predictive, as well as the selection of drugs that can be utilized. So we're looking really a lot more now at the molecular aspects. But I think to say that medical oncologists don't use TPN or don't agree to it is not the current treatment regimen that we use.
Oh, and I respect that, and I agree with you that there's no question that the molecular biology rules everything. No matter what we think about the cancer, the way it looks under the microscope, the way it looks at time of surgery, what the genes are doing is going to determine the outcome of the response to chemotherapy, the overall survival for a patient. There's no question about that. And we're all eagerly awaiting the day when we can do molecular diagnostics on an individual person's tumor, find out what genes are driving the cancer biology the most, and if we actually had something that could target those areas, then we'll be really making progress, but we're not there yet. And just in my personal experience, talking to medical oncologists about treating patients with end-stage cancer, particularly with carcinomatosis, I've not had a lot of support with proposing putting people on chemotherapy, but I'm glad to hear that there are medical oncologists who are willing to do that, because I think it actually can be very beneficial. So as the nurse over here mentioned, there comes a point in time where people are transitioning not only now from palliative care, which can be given along with treating the cancer itself, but to something that we call hospice. And so for most people, I think if you polled the audience, when people hear the word hospice, they really equate hospice with dying. And what hospice really is a form of palliative care for people with an incurable condition to which they could succumb within the next 6 months, and who are no longer now receiving treatment directed towards that life-threatening illness. So really all it takes to qualify, if you will, for hospice. And the way I describe hospice is a type of insurance benefit that you have. The requirement, though, to use that benefit from your insurance is that your doctors have to think that if something happened, if this person died in the next 6 months from the disease that we have been treating and fighting, I would not be surprised by that. Then that's really all that's required to be able to be eligible for the hospice benefit. It doesn't mean that the person is going to die in the next 6 months, or that they have to die in the next 6 months. And the goal of hospice is to help patients and families live as well as possible for as long as possible while dealing with the physical and emotional effects of death and dying. And so a lot of people think that hospice means if you're going on hospice that your expectation is you're going to die shortly, and that it is a means of hastening that process. Hospice can occur at home or in a hospice house. It provides the same level of care as cancer-directed treatment. It is centered around goals of the patient and their loved ones. And most importantly, it is not designed to hasten the end of life. But rather, it is not just simply medicating a person. It can continue as long as needed. So if the expectation again that 6 months is for the benefit purposes, if somebody lives for a year or years, they can continue to receive the hospice benefit. And we've actually had people graduate from hospice, gotten better and come off hospice. Or if new treatments come along directed towards that person's particular problem, they can come off hospice and receive those treatments. So it is not a one-way street. It is a two-way, you can go either way. Like I said, it can stop if a situation improves or new treatments become available. And the same providers are involved in providing hospice care, again, a comprehensive, multidisciplinary approach towards helping people with a life-threatening condition. This is the landmark study that I mentioned earlier about the involvement of palliative care early for patients with metastatic non-small cell lung cancer. Non-small cell lung cancer is a very difficult cancer to treat, and in the metastatic setting is really considered incurable. And as I mentioned before, the patients who received early palliative care had not only significant improvements in both the quality of life and mood, but less aggressive care at the end of life, and lived almost 3 months longer than the patients who did not receive palliative care. So this is never an easy transition, not for the doctor, certainly not for the patient, and not for the family involved. There's a large focus now by the American Society of Clinical Oncology on advanced care planning, and they're really cancer care planning, and they're really trying to encourage doctors, surgical oncologists, medical oncologists, primary care doctors, to get involved early to talk to people who are dealing with cancer, to start thinking about some aspects and educating people to ask the questions that they think are important. For example, what is the diagnosis and what does this mean? What is my prognosis or my chance of cure? Remember, I already talked a little bit about how doctors tend to shy away from talking about prognosis in specific detail. What are my treatment options? What is a clinical trial, and are there any trials that are appropriate for me? What treatment plan are you recommending and why? If it's chemotherapy, why chemotherapy? If it's surgery, why surgery as opposed to something else? What is the goal of this plan? Are we working to cure this disease? Are we working just to slow it down? Are we treating the symptoms, or both? Am I healthy enough to have this treatment? What are the potential risks and benefits? Are there other alternatives? How often should we reassess the plan? Would palliative care help me now? What is hospice care? Where can I get support for myself and my family? And this brochure that is available on the ASCO website offers a number of places where people can get more information about these issues. And specifically for PMP and appendiceal cancer, there are certainly websites available that offer a lot of good advice and support. And so I'd just like to leave with the impression that palliative care is not about giving up, but it really is about optimizing and can potentially actually improve survival for people with advanced cancers. That's the one study that I showed, but there are other studies that have shown the same thing in other life-threatening cancers such as pancreas cancer. And that hospice care is really not about dying, although that may be what gets you onto hospice care. It's really about living as well as you can, as long as you can. And changing the focus of the treatment to living as well as you can and as long as you can. But it's not about stopping treatment or hastening death. And with that, I'll conclude, and I'll be happy to take any questions.